It is my honor to introduce Dr. Martha Sajatovic, who is the expert, and I am emphasizing the expert in old age or bipolar disorder in old age. Just to give an example, recently there was a review of how to come up with the best group to do guidelines for the treatment of bipolar disorder, and an area that was missing was in the elderly. And there was a consensus in the group that the best person to do it would be Martha Sajatovic. She is, as mentioned, an expert. She's Professor of Psychiatry and Neurology at Case Western. And she holds 2 chairs. First one is in Neurological Outcomes, the Willard Brown Chair in Neurological Outcomes, and the second one is the Rocco L Professorship in Child and Adolescent Psychiatry. She is widely published, over 400 peer-reviewed publication, and received a number of awards, such as the Exemplary Psychiatrist Award from the National Alliance for the Mentally Ill, and has received numerous grants. So, Martha Sajatovic, it is an honor to have you here today. I'm sure everybody will gain a lot from your presentation. Please go ahead.
Thank you. Thank you for the very kind introduction, Maurizio. It is really a pleasure to be here. And also a pleasure to talk about one of my favorite topics, older age bipolar disorder. I'm going to use the acronym OABD, and hopefully I can provide you with a little bit of an update on what's new with the old, and a brief overview of some of the emerging research in this topic. I'm not advancing. I'm sorry. Let me try that again. Let's see if I can get this to work this time. My apologies. It was working before. Let me try it again. Okay.
Perfect.
All right. Sorry about that. So there's my disclosures. If anybody has any interest, you can get it from your Grand Rounds organizers. I do consulting and have research grants from both non-commercial and commercial entities. Our objectives today are going to be gaining familiarity with the epidemiology of OABD, familiarity with the assessment of individuals with OABD, and also a little bit about treatment of individuals with OABD. So just to give you a background, sometimes I get asked, what is this and why are you so interested in this topic? And I guess I would push back and say that everybody really needs to be interested in this topic of aging generally because of what is happening with global demographics. And the US is kind of ahead of the curve in terms of old age being more a bigger proportion of our population. So for instance, the number of people age 60 and older has doubled since 1980. The number age 80 and higher will increase fourfold to about 400 million by 2050. And currently, adults over the age of 65 outnumber kids under the age of 5. This is the first time in the history of the world that is true. By 2050, the elderly will outnumber all children under the age of 14. Again, in the history of the world. So this is really a big deal. The majority of the older people will live in low and middle income countries, and that's just, population wise. And this number will increase to 80% by 2050. So, even if you don't consider yourself to be kind of a geriatric specialist, I would say that you need to get ready for this change in global demographics that's going on. When we pivot a little bit to bipolar disorder specifically, that demographic change that's happening globally is happening in people with serious mental illnesses, such as bipolar disorder. We have very limited systematic data, and they are known to be a high-risk group. We don't know very much about late versus early onset illness. We know that cognitive impairment occurs more often, and people who have dementia have a lot more costs, both individually and as a society. There's a lot more medical and neurological comorbidity, and we need to incorporate healthcare planning in order to meet both the workforce demands and the overall costs. This is an old slide by Dilip Jesti, but I think it's a good one. It looks at the estimated prevalence of Americans who have major psychiatric disorders, and you can see that, that population that's around the age of 45 is, kind of slated to be about the same proportion. But again, tapping into that global demographic change, those who are elderly, 50 plus, and you'll see why I'll use that word 50 plus in a minute, are increasing. So let's talk about the epidemiology of bipolarity and aging. 9% of geropsych inpatients and 6% of outpatients have bipolar disorder. In the community, of course, it's quite a bit smaller. Community samples using an instrument like the Mood Disorder Questionnaire, MDQ, have found somewhere between 0.5% and 1% of people age 65 and older who have bipolar disorder. If you look at bipolar 1 and 2 categories cumulatively, it affects between 0.5% and 1% of the population over the age of 60. So the numbers are slightly less compared to younger population, and that is almost certainly due to the premature mortality that we see in people who have bipolar disorder. So I've been asked, what do you mean by OABD? And what I mean is that it is a relatively broad umbrella, includes those who've been ill for many years. So the classic onset of bipolar disorder is relatively early in life, late teens or early adulthood. But OABD also includes those who have an onset later in life, especially after the age of 50. It also includes people who have medical conditions that then go into bipolar disorder. This is sometimes called secondary mania. It includes people who have a mood disorder history, usually unipolar major depressive disorder, who then later in life exhibit a manic or hypomanic episode. We know that as with younger people, older people with bipolar disorder are often missed or underdiagnosed. It's complicated by comorbidity. And it's actually, unfortunately, not uncommon to see somebody with bipolar disorder who's older who gets told that they have Alzheimer's or some type of dementia, when in fact they have a primary mood disorder, namely bipolar disorder. I've been very fortunate over the last decade or so to be involved with the ISBD, the International Society for Bipolar Disorder. Dr. Towen has also been a very prominent leader in this group, this global group. But ISBD has had a OABD task force now for about a decade. And this task force put together a position paper close to a decade ago now, breaking down late onset versus early onset bipolar disorder. This is a graphic from that publication. So early onset is typically described as a first manic or hypomanic episode under the age of 50. Our task force proposed potentially moving that to 40, knowing we know about premature mortality in bipolar disorder. So people with bipolar disorder lose, on average, 1 to 2 decades of life compared to the general population. So there's the early onset group, and then there's the later onset. The task force recommends consideration certainly of cutoff of age of 50. So if you have a first manic or hypomanic episode age 50 or later, we would definitely call you late onset. The task force recommends that we consider even moving that to 40, again, because of premature mortality. And then there's that big umbrella that people with OABD are those who are age 50 and older. Now, there are some controversial topics that we identified back in 2015, but these remain controversial. Questions about neuroprogression in OABD. So is bipolar disorder a neurodegenerative condition that actually causes damage to the brain and body, resulting in dementia? I would say the jury's still out on that. Depending on what types of data you look at, the answer might be yes, the answer might be no. Imaging studies have not really conclusively been able to show that neuroprogression is happening, but case registry or cohort studies might lead one to respond that yes, it is a neuroprogressive condition. Talked a little bit about late onset. So whether it's 50 or 60 is the break point. Late onset illness is less likely to be associated with a family history of bipolar disorder. It's more likely associated with medical or neurological conditions like stroke, especially right hemispheric events. However, in older people, differentiating between dementing conditions and bipolar mania can be challenging. For example, frontal disinhibition syndromes can look a lot like bipolar mania. One thing to maybe think about if you're a clinician, you're trying to parse those two out, is that bipolar mania is characterized by elevated mood and a decreased need for sleep rather than simply disturbed sleep, which is more common in dementia syndromes. Comorbidity, especially medical comorbidity, is the norm rather than the rule in OABD. And people average 3 to 4 chronic medical conditions. Their conditions are similar to what the general population has: hypertension, diabetes. You need to consider when you look at older samples with bipolar disorder that they probably represent a healthy survivor effect. So people who are more ill medically tend to die earlier. So you want to be careful about the types of extrapolations you do from older samples. Standardized mortality ratios that have been conducted in research samples with bipolar with BD, 2.5 for men, 2.7 for women. So anything over 1 indicates a greater risk than the general population. As I mentioned, the types of comorbidity you see also contribute to death: cardiovascular disease, suicide, cancer, and lifestyle conditions, lifestyle issues like smoking, poor diet, or use of alcohol and other substances almost certainly contribute to this premature mortality that we see in OABD. Interesting study by one of my former colleagues from Case Western suggested that even things like increased body weight can contribute to the comorbidity and early mortality. So Dr. Kemp found that for every 1 unit increase in BMI, we saw a decrease in bipolar disorder treatment response by about 7%. So you can imagine that, all of the downstream negative effects that leads to. We're going to shift gears a little bit now and go into the assessment of OABD. So this is a classic slide that talks about the different symptom domains in bipolar disorder. So there's the classic manic symptoms, euphoria, grandiosity, pressured speech, and so on. And then the depressive realm, so that's dysphoria, anxiety, irritability, hostility, the psychotic constellation of symptoms, and then what we know are probably underrecognized, but they're all the time, even in euthymic states, as cognitive symptoms: disorganization, inattentiveness, processing speed, and so on. Let's talk a little bit about specific presentations of both mania and depression in OABD. So in older people with bipolar disorder, manic symptoms may be milder. However, they can also present with mixed states or agitated states. They're more likely to be irritable and have higher rates of treatment resistance, particularly if it's a new onset bipolar disorder. So, you think about some of these stereotypes that we see with aging is that people get more irritable. And in fact, what could actually be going on is that they may be having a manic presentation or a mixed manic state. On the flip side, depression can be manifested as both depression or irritability, sleep, and other biological functions like psychomotor agitation or retardation can be common. Cognitive impairment can lead to a dementia-like presentation. And unfortunately, even in my own clinical practice, I've seen older people diagnosed as having Alzheimer's disease when in fact it's really related to symptomatic and cognitive impairments related to their bipolar disorder. On average, in older people with bipolar disorder, depression usually precedes mania by an average of a couple of decades. A very nice review in the Annals of General Psychiatry by Lubitsch and colleagues did a compare and contrast of the characteristics of OABD versus younger bipolar populations. So some of these things I've already touched on, the differences in family history, the differences in comorbidity. But I think you can see some of the specific differences. So cognitive impairment is more likely, and potentially an inappropriate diagnosis of dementia compared to things like ADHD, which may be more common in older people, in younger people, excuse me. So then I wanted to tell you some updates. So I am part of this ISBD task force that is focused on older age bipolar disorder. And several years ago, we had a really terrific opportunity to apply for some research funding through the Bowden-Massey Strategic Research Initiative in Bipolar Disorder. And this was supported by Dr. Charlie Bowden and his wife, Virginia Massey. We are very, very grateful to them for supporting this research initiative. Our task force group applied, and we're very fortunate to get funding. So our idea was, given the paucity of data and knowledge that there is an OABD, we were going to do a collation of research data sets and clinical data sets, pull together a global team, and try and make some sense of this aggregate data and see what we can learn about older age bipolar disorder. So we have some information on the ISBD website on the GAGE-BD project. It's what we call it, Global Aging and Geriatric Experiments in Bipolar Disorder Database. Please feel free to reach out to me or look on the ISBD website if you want to find out more about this. I have reached out to Dr. Tohen, and other colleagues at your institutions to see whether there might be folks at your facilities who would be interested in contributing data to the GAGE-BD project. I'd be very interested in discussing with you if you think you have a data set that might be a good fit. All right, so let's just take a step back. So our GAGE-BD data set is not the only data set that's out there that has compiled aggregate data from bipolar populations or other serious mental illnesses. So Iconic BD, there's the Psychiatric Genomics Consortium, a project called the Enigma Project, which focused on neuroimaging and genetics. So these have all been global projects or national projects that have used the strength of big data to learn new things. What we did with GAGE-BD is we've had sequential waves now of data collation and data analysis. Our first wave of data had 19 studies, almost 1,400 BD cases. You can see from this world map where we've drawn our samples. We've tried to be as representative as possible. And when we looked at our first map, as you can see here, we realized that there were large chunks of the globe, including whole continents, that were not represented. So in our wave 2 and now in our wave 3 data collation, we're trying to have a more representative sample and have data from as much of the globe as we can. But you can see most of our data, at least in wave 1, came from the Americas or Europe. We did have one site in Australia, one site in Asia. So our first question, our first analysis was to look at the presentation of bipolar disorder symptoms and age. This is the aggregate analysis, and what we found in our first sample is that it appeared that there was less severe mania or manic symptoms with age and less severe bipolar depression symptoms with age. So that was a somewhat unexpected finding. We actually expected that mania might be more attenuated. We didn't expect that depression would be more attenuated. But that's what we found. Then we also looked at somatic burden, so medical comorbidity. And as we did expect to find, somatic comorbidity was very, very common. So this is a breakdown of the types of medical conditions we saw in our OABD sample. So At the top of the list was cardiovascular conditions, followed by musculoskeletal, respiratory, endocrine, and you can see GI and GU were not very far behind. So very common. It was also very common to see people with multiple conditions. So again, medical comorbidity is the norm rather than the exception in OABD, and it complicates treatment considerably. We found an average of between 2 and 3 medical comorbidities. And because we had to use aggregate data, we broke the comorbidities out into 8 comorbidity groups. It didn't allow for as much granularity as what we would have liked. And then the conditions that were significantly associated with age were those noted here: cardiovascular, GI, musculoskeletal, and endocrine. Then the next thing we looked at was the association between medical burden, functioning, and BD symptoms. We found somewhat surprisingly is that age, gender, and comorbidity were not necessarily associated with functioning. However, what appeared to be a very strong driver of functioning was bipolar disorder symptoms. So for every 10-point increase in severity on the Young Mania Rating Scale, or Weimer scale, we saw a just over 6-point drop in the global assessment or functioning of GAF. And there was a similar relationship for depressive symptoms. So an average drop of 9 points on the GAF for each transition to a higher category of depressive symptom severity. For depressive symptoms, looking at our aggregate data, we didn't find that the data sets used a uniform measurement of depression severity. So unlike mania, where most data sets use the Weimers, we found different scales being used, the Hamilton Depression Scale or Montgomery-Åsberg Depression Scale, or, PHQ-9. And so we broke them down by severity, ordinal categories. So anyway, the most profound driver of functioning in OABD appeared to be symptom severity. So that makes a very strong case for the need to assess and manage symptoms regardless of people's age, and that we need to be fairly aggressive in treatment across the full lifespan. We did another study looking at mixity. So the background is that mania and hypomania or depression can occur concurrently. DSM-5 has a mixed feature specifier, so manic or hypomanic episode with 3 or more depressive symptoms. The flip side for manic symptoms, it's not clear how mixity might present in OABD. So we did a cross-sectional analysis using the GAGE-BD dataset, over 800 participants from 12 international studies. We had 4 mixity groups that we pulled out from those 800-some cases, and they were classified as asymptomatic, mixed, depressive only, or manic only. We looked at, we used the Global Assessment of Functioning, or GAF, as a functional outcome assessment. And we found as the mixed group, which made up almost 70% of the sample, had lower GAF versus the other group, in spite of the fact that they looked similar on their demographic or other clinical variables. And then within that mixity group, so that 70+%, depression but not mania predicted GAF. So the story kind of gets a little more complicated here. Mania is still a driver, but depression appears to be a stronger driver of functioning in people with mixed symptoms. So then about 2 years ago now, we pulled together a second wave of cases. This time we had a slightly different group of people that contributed. So we did have a site now in Africa, a little bit more in Asia and the Middle East, also still a lot of sites from the United States. So we have wave 1, we have wave 2 now. Wave 1 is the blue bars and line fitted, and then red is wave 2. Wave 2 is a little younger than our wave 1 participants. We've got about 1,300 cases in wave 2. This is what we look like now. Aggregate, we've got about 2,600 cases with an average age of around 54.3. 68.6% of, I'm sorry, 60.3% are women, and the majority are bipolar 1. So around 3/4 of the cases are bipolar 1. So let me shift gears a little bit and talk about the treatment of OABD, and I will weave through some of our findings from GAGE-BD data set, but I also want to talk about some other literature. So let's go back to our ISBD task force. And one of the questions that we asked our group over the last decade is, what do international treatment guidelines say about how best to treat people who are older who have bipolar disorder? So we collated 35 guidelines from 6 continents and 19 countries. We did a systematic review of studies published, or reports published between 2005 and 2015. What we found is that, unfortunately, most guidelines have no separate section on OABD, and what they tend to do is extrapolate the general principles for medication similar to younger adults. And they're not really based upon actual data from OABD. That is a problem, and it points for a critical need for new evidence. So I've already shared with you some of the differences in older people and younger people with bipolar disorder. They have more medical conditions. The comorbidities are different. They may have different symptom presentations. They have premature mortality. So you can't necessarily say what works for younger people is going to work for older people. Some of the key clinical issues that we have to think about when we treat older people with bipolar disorders is, this is again coming from a very nice paper by Lubitsch. Differences include metabolic capacity for drugs, a higher sensitivity to drug-related adverse effects, more risk for drug-drug interactions due to concomitant medication for somatic diseases, and then medication side effects. So let me just draw, for example, the risk for drug-drug interactions. So I already told you that on average, people have somewhere between 2 and 4 medical conditions in addition to their bipolar disorder. Let's just say, for instance, they're on 2 drugs for their bipolar disorder, and that would not be uncommon for somebody treated in the United States for bipolar disorder. And then let's say they have 3 medical conditions and they're on 1 drug per medical condition. And that, I think, is relatively conservative. If you look at most people who are older, you're going to see they're on more than 1 medication for a medical condition. But let's just say, be conservative and say it's 1. So now if you take the 2 drugs for bipolar disorder and their 3 medical comorbidities, you're up to 5 drugs. It's going to be pretty hard to avoid drug-drug interactions with 5 drugs on board, just as a base rate. So not surprisingly, adverse drug reactions increase as a function of age. And if you look at this, this is what I would say is an oldie but goodie graphic. So adverse drugs per 10,000 of the population stay kind of relatively low and relatively stable until around the age of 50. And then they start increasing pretty rapidly. So what are the best treatments for OABD? Our current FDA approval process does not differentiate between mixed age versus older adults. So, whatever we talk about here, if there's an FDA indication, you're not going off label by prescribing that to a person who's in their 60s or 70s or 80s. First-line treatments for bipolar disorder include lithium, selected anticonvulsant drugs, and antipsychotic mood stabilizers. The efficacy data that we have specific to OABD appear to suggest that BD symptom response is fairly similar to younger people. However, tolerability or side effects is usually the rate-limiting element. There is some indication that some drugs can help protect the brain, potentially against developing dementia or cognitive impairment over time, and we might call these drugs neuroprotective. There is a growing body of literature that psychotherapies can be helpful, especially those that integrate both physical and mental health, knowing how important somatic comorbidity is in OABD. So traditional mood stabilizers like lithium and the mood stabilizing antipsychotics are important. And then, just as with mixed age patients, antidepressants, other medication treatments, ECT electroconvulsive therapy is a particularly important treatment for older people. It's used a lot for unipolar major depression, and it can be a useful therapy as well for older people with bipolar disorder. I mentioned psychosocial approaches or psychotherapeutic approaches, and then of course, enhancing medication treatment adherence. So the literature suggests that on average for people with chronic health conditions, rates of suboptimal adherence can approach 50%. So that's a kind of low-hanging fruit opportunity to improve medication or treatment response in bipolar disorder. To the best of my knowledge, there is only one prospective randomized controlled trial that has been conducted specific to geriatric bipolar disorder. And this was a study led a number of years ago now by Dr. Robert Young. This was a 9-week randomized controlled trial of lithium versus divalproex in late life type 1 bipolar mania. Our group at CASE was one of multiple participating sites. This was an NIMH funded study. So in that study, we enrolled people over the age of 60. We did exclude people with dementia, randomized them to receive either lithium versus divalproex. If after 3 weeks they were still having significant bipolar manic symptoms, they were allowed risperidone as a rescue medication. And then we followed them for 9 weeks until the end of the study. We actually expected divalproex to outperform lithium. However, we did not see that. The Young Mania Rating scores on the 3-week completers really showed almost an identical response to lithium and divalproex. So both of these evidence-based medications are good treatments for type 1 bipolar disorder in geriatric patients. But to get to this issue of lithium and certain drugs that might be neuroprotective. Lars Kessing, who has the good fortune to be working in Denmark, that has these wonderful cohorts available for researchers to follow as part of their national health system, identified that the rates of dementia can be linked to the number of lithium prescriptions. So if you are prescribed lithium and you get more than 2 refills of lithium, indicating that you're prescribed it for a reason, bipolar disorder, that your rates of dementia actually start to normalize. And it suggests on a population level that lithium might actually be a predictor of brain health if you have bipolar disorder and you're prescribed lithium. But then there's the issue of side effects from lithium. So Ken Shulman from Canada, also using a national health system data set, looked at the incidence of delirium with new users of either lithium or divalproex. So he looked at older adults, and he used benztropine as a kind of base rate. We know benztropine is bad for your brain, and it can increase the risk for delirium in older people. And in fact, he did find that there was not, the lithium was not associated with higher rates of delirium, and in fact performed better than divalproex in a large sample of Canadians who were prescribed divalproex versus lithium versus benztropine. So lithium does appear to be at least safe for brain health when used in older people. So then let's go back to our GAGE-BD sample. So there's not a great deal of data on the use of antipsychotics in OABD. We decided to look at GAGE and see what our data set said. Our first analysis was a cross-sectional sample from 16 studies reporting data on older adults over the age of 50. So we had a sample of just over 1,000 cases. And actually, this was kind of somewhat to my surprise, but nearly 47% of them were maintained on antipsychotics. I did not expect it to be that high. But there it was. And then we compared those who were prescribed antipsychotics versus no antipsychotics, so APS here. And after adjusting for effects of study cohort and other relevant covariates, we found that the group that was on antipsychotics tended to be a little younger. They were less likely to be employed. They had more psychiatric hospitalizations, were less likely to be on lithium. So some proxy markers that perhaps they had more severe bipolar illness. We also compared the first generation group versus those who are on second generation antipsychotics. Those on first generation antipsychotics had more psychiatric hospitalizations. Again, another potential proxy marker for more severe bipolar disorder. What we don't know is whether those people who were on first generation were those who were prescribed a first generation to begin with and just stayed on it, or whether they got prescribed a second generation first and then had maybe a suboptimal response and were then put on a first generation. So because this was a cross-sectional study, we didn't have that information to draw from. Here's the graphic. So, these 16 studies, and you can see pretty much halfway across the board, although there was a little variation across sites, but overall, a good proportion of people maintained on antipsychotic drugs. If we look at other data outside of GAGE-BD, there's been a few studies that are post hoc analyses looking at subgroups in clinical trial samples. So there was a secondary analysis looking at lurasidone in acute bipolar depression. So these are from the pivotal FDA trials, looking at people age 50 plus. So lurasidone and combined doses versus placebo in the monotherapy trials versus adjunctive therapy trials of adjunctive therapy with lithium compared to placebo. And you can see that the samples are relatively small, 20s to 50s in each group. Treatment emergent adverse effects, as you can see with lurasidone, tended to be most commonly nausea, somnolence. Somnolence and fall risks is particularly a side effect of concern in the elderly. However, we did not really see that jump out strongly here as hugely different from placebo. In the monotherapy analysis, we did see separation in the older group. So this was published in the journal Clinical Psychiatry well over a decade ago, that lurasidone separated pretty quickly from placebo in change in the Montgomery-Åsberg Depression Rating Scale. We did not see a separation from placebo in the adjunct therapy group. And then I do want to mention that there is an FDA advisory, a black box warning for antipsychotic drugs used for the treatment of behavioral disorders in elderly patients. This is a class label. It is based on data from dementia patients, dementia samples. We know that antipsychotic drugs are used off-label to treat behavioral disorders in elderly patients. The death causes from the FDA advisory were mostly heart-related, so sudden death, cardiovascular disease, or infections. So how this applies to bipolar disorder populations is not clear. As I said, our type 1 bipolar study led by Dr. Young did exclude dementia patients. However, I do have to say a new occurrence that has happened just within the last year and a half is that the FDA has actually given a indication for an antipsychotic drug to treat behavioral disturbances with people with dementia. So that, the story continues. I would say if you have somebody who has bipolar disorder who does not have dementia, I would use your good clinical judgment to use evidence-based treatments for bipolar disorder in that older individual. To go back to this issue about neuroprotection, there is some neuroimaging findings that suggest long-term lithium use is associated with an increase in total gray matter compared to people who were not treated with lithium. Lithium treatment is associated with increased hippocampal volumes and a decrease of white matter microstructural abnormalities. The story on antipsychotic use is less clear. Something called fractional anisotropy, or FA, shows coherence of white matter tracts, so greater white matter tract integrity is seen with better brain health, and long-term antipsychotic treatment has been associated with a decrease in FA in frontal limbic regions, but increased FA in fronto-occipital regions. So a little bit of a mixed story with the antipsychotics, and hard to know. It doesn't appear, in contrast to lithium, that there is a stronger story to be told around neuroprotective effects. So our OABD group for the International Society for Bipolar Disorder has looked at what types of recommendations we should make if you're going to study OABD, or even in clinical practice settings, what types of special characteristics or outcomes should you look at? We did a review of the literature of OABD studies and found that most studies did collect information on age, gender, level of education, less commonly ethnicity and social support. Most of them use structured diagnostic interviews like the SCID or MINI, and variably looked at course and chronicity measures. Symptom scales were sort of across the board. The Young Mania Rating Scale is the most common used mania scale in OABD studies, but depression is more of a mixed bag. And then comorbidity measures. It seemed that most of the studies looked at cardiovascular risk, diabetes, weight, and cumulative medical burden. So studies really do seem to gravitate toward the idea that you need to look at chronicity, you need to have standardized measures for BD symptoms, and comorbidity needs to be measured in a kind of structured way. Our team in the task force worked on putting together recommendations for a minimum data set to assess OABD. We did a literature review and a Delphi iterative process. The relevant articles were assessed looking at the types of clinical cognitive biomarker neuroimaging data collected. And what we have recently published some recommendations on what are the minimum data variables that you should collect if you're doing